So to carry on, I'm going to deliver this talk together with Liz, and we will talk a little bit about our experiences and what kind of work is going on in the UK. So I think, especially coming from a medical background, I think this is the question you face from different colleagues, and whenever you write policies and guidelines and you try to create new things, you have to face that question, where is the evidence? And we know that the family-centered care is now clearly a very well-recognized core value in neonatology and how we work. When you look at the Cochrane collaboration, which is usually kind of the strongest evidence we usually review, there is only kind of one update on family-integrated care models, and the last one was in 2012, so long time ago. And it wasn't focusing on the preterm population, but kind of in generally between 0 and 12-year kind of pediatric population. And however they kind of appreciated that there might be some benefits, they clearly stated that more research is needed to validate the effect of these kind of care models. So we do know, and we have heard Kara's excellent talk, and it was amazing, that there is definitely emerging medicine. And even the people who kind of demanding medical outcomes will have to accept that in these care models, medical and kind of mental health outcomes for the parents are better. So we understand that this is going to race to the evidence-based medicine with these, and we know that the Canadian network's actually in the process of implementing this care model as a standard of care nationally, and many international groups will do that, as Liz will talk about it. We do have national guidances, so you're all aware of kind of the NHS England neonatal service specification, which clearly kind of states that involving families is a strategy point. And again, also the BLISS Baby Charter was kind of the first giving and describing the rights of a preterm baby and what kind of values we should working towards. It's part of the BAPAM 5-year strategy, which was kind of published in 2014, that strategic plan. However, I don't feel that so extensive work is going on at the present at that level. There is a need for change, and we do know about parental experience. Probably the two most known kind of tool and parental survey which was done. One was the POPI project, which is a little bit more academic approach, and they basically interviewed neonatal units, kind of doing just a general survey, and then more deeper interviews for 55 parents. And that was led by the MPU and the RCN Research Institute. The last PICare survey, again, was a couple of years ago, and that was more extensive, involving 88 neonatal units, and in each unit, around 100% have received the questionnaire and answered in different kind of scenarios and sections. And they have identified that most of the least positive experiences were around information received about neonatal care, communication between families and neonatal team, and emotional support. It also identified that there was a huge variation between practices nationally, and the London units falling behind external areas. So we all work along these chapters. We know very well, and Caroline touched base on that at the very beginning, containing the 7 core principles, which will show how kind of respect and support these vulnerable babies. And many units have actually used the BLISS audit tool and accreditation to assess where they are in that project, achieving family integrated care. It's a great tool, and I think why it's great, because it's nationally used, so it's quite easy to kind of add the family delivered care or family integrated care as a gold standard on the top of that, and maybe this is something as a national working group we're looking into the future. And in the workshops in the afternoon, how we design, that actually you will have the different teams who are trialing, pioneering these care models. And in the workshops, you will have opportunity actually to look deeply into this project, identifying factors which helped success or which were the barriers locally, look at the material which each team has designed. So we hope that that's going to be a great start and a lot of takeaway ideas for you to use in your local area. And I think Caroline talked about this national working group that we aim that we share knowledge and best practice about FICare in the UK. we will continue to carry on with these national study days, and hopefully more and more people will be part of that. And there are discussions how can we expand the BLISS Baby Charter to add a kind of a gold standard additional part around family integrated care.
I need to sing a song now, but anyway, don't worry, I won't. So I just wanted to come in at this point and just talk a little bit about what is happening across the whole of the UK. I think it's really important that the whole purpose of a day like today is all about us learning from each other, learning from mistakes that we've made, certainly, so that other people going forward can learn and hopefully avoid those things. So in Leeds, we've already got FICare up and running for a couple of years now. May will be our 2-year anniversary at one of our hospitals, and we're taking it across to the other one later this year. Birmingham and the West Midlands network are setting up as a network project, and Claire and Gemma from Birmingham are here and are running one of the workshops this afternoon. I think Maha's here from Swansea, where they're up and running, and also Neil from Glasgow, where they're up and running as well, although you didn't sound quite so sure when I just asked him. And I would be really interested to know where everybody else is in their kind of journey towards family integrated care, or what their reticence is into doing it. So in our workshop this afternoon, I will try and get you all to write down where you come from and what you're doing. I know lots of places have got plans afoot for starting family integrated care. Rebecca's already stood up. They're implementing as a network, and I think the North West are as well. Thames Valley and Wessex are definitely very keen, as are the Highlands and Islands, and I think Leicester and the Northern networks as well are all aspiring to these family integrated care. Internationally, there's some amazing work going on. Carol has clearly told you all about what's happened in Canada, Australia and New Zealand. One of the things that she didn't mention was the work that has happened in China, which, just really briefly, there's a doctor that trained in Toronto for 2 years and took family integrated care back to her unit in a town in China, which I won't even begin to try and pronounce. But their system is that you can, if you have a pet baby in a neonatal unit, you can look through the window at that baby for 10 minutes a week. I thought it was a day, but it's a week, I'm told. And she has implemented family integrated care to great success, and in fact has even got 18-month outcome measures, which shows much better neurodevelopmental outcome in those babies. And then there's lots of other work going on. I know that Imperial are hoping to get involved in Rwanda, and I'm going to Vietnam, where they're very interested as well. So I think that it would be great if we could all move forward together. We've heard lots about this national steering group that BLISS are hosting for us. I think it would be great to get BAPM to endorse family integrated care as a standard of care, and that we should all continue to share our experience. And I'm a sucker for these sort of pictures that you find on social media, but if everyone is moving forward together, then success takes care of itself. I like that. I'll hand back to Aniko.
So as we are hosting this study day, we were very keen that we share a little bit in more extent our journey and how have we come along, doing family integrated care. And probably one of the kind of personal experience was when I was in Hot Topics, and Professor Shawley basically presented some of the pilots and kind of the plans about the randomized study. And probably that was when I really got motivated and enthusiastic that this is something we need to have at Imperial. So if you see, it's probably now more than 3 years of work where we started our project outline, and we had a great support. It's probably quite, sorry, I'm going to stop saying probably. It's coincidented with the new trust management and our new executive team, and Bob talked about the QA strategy of the trust. So we were extremely lucky to have a great support from higher leadership and a healthcare charity to enable us to really to achieve our aims. So we have made an application for funding, and we have tried to build a collaboration with Mount Sinai and learn about their experience as much as we can to design our kind of own care model. We have a lot of existing model. At Imperial, it's not like a one-day implementation of this care model. We're working along these values for several years. I think that's why collaboration is so important, because even working in our own network, I know not everybody is aware what one unit is doing to another, because we are in separate walls, we have separate policies. Nobody gonna come and experience, how are we delivering care. So when we visited Toronto and we saw the Mount Sinai team, actually we felt, we are doing a lot of things already. We have a lot of support in place. We have a lot of resources for parents in place, but it's not visible as a structure. We don't call it as FICare, and we need a structure around. We have a very established multidisciplinary team who have a developmental care specialist, psychologists, speech and language therapists, breastfeeding consultants on both sides, dietitian. And I know that not every unit is lucky to have all those researches. We have a multidisciplinary team who is doing the MDT ward rounds every week, which is very well attended with parents. And parents were involved previously in that ward round, however, not formally presented their baby. If you look at that table is showing our NNAP, the National Neonatal Audit data, that kind of working along with the family-centered care values, for a long, long time, we have above national average breastfeeding or breast milk feeding at discharge, which is usually about 80% or above. And having the lactation consultants available was definitely a great support to achieve that. We also have one of our own milk bank, which is one of the oldest milk bank in the UK. A smaller QA project we did a couple of years ago was where probably family delivered care or family integrated care needs to start, is having unlimited parent access. Similarly to the old Mount Sinai Hospital, our nurseries are shared nurseries. So we have large rooms between 6 to 8 cots or so. And it was usual practice on our ward rounds that parents have to leave the discussion and the ward round when other babies were called back. So basically, one of our nurses went out to the parent room to get them to come into the nursery. They were allowed to stay when we discussed their babies and their plans, but then they had to leave. And you can understand that when you have 6 cots in an intensive care nursery and the ward round probably lasts for 2 or 3 hours, that's a significant time in the mom's life, and it's a significant separation time, additionally to the twice daily medical and nursing handovers. So what we have done a small QI project, and we implemented headphones to use during whenever confidential information is being discussed in the nursery. We have done a pre-implementation and a post-implementation audit, and I'm not going to talk a lot about kind of our results, but this was just one question when we asked the parents that thinking back over the last week, I have been asked to leave the nursery during the ward round on the handover, kind of how many times, and the answers are running from never to more than twice a day. And you can see that the majority of the parents, more than 70% have really experienced that either on a daily basis or more than once a day. And you can see that what we wanted to achieve is to eliminate this separation, and we were very successful, because after implementation, 70% said that they never been asked to leave the nursery during ward rounds and handovers. And this was just a small change. It doesn't really affect how you work on the day in the neonatal unit. It's just that the parents have 2 headphones available at the cot side, and they put that on whenever a confidential discussion happening around them. And they can just take that off and join the discussion when their baby is being discussed at the ward round. So it was a small change, but the feedback did show that it was a great achievement for parents. And I think this practice is now on the BLISS website as well, kind of as a best practice guideline, and we shared our parent information leaflet. Similarly, we have a discharge liaison team in place, and this team will provide ongoing support as a neonatal outreach team. These units were one of the pioneers in home oxygen. We're sending babies home on oxygen for probably more than eight years, and also support long-term tube feeding for babies who have neurological abnormalities or such special need. A couple of years, this post-discharge parent group was also established, which is a next step parent group called. And this is running every week, but in different sites. We have the St. Mary's and the Queen Charlotte site with a level 1 and level 2, and have an MDT approach and have some specific topics kind of rolling. And this again gave a great feedback that parents feel more comfortable to join this group than in their neighborhood where healthy term babies are in their environment. And however, we don't have such an established veteran parent group like in Mount Sinai. What we used that, for example, when a baby went home on oxygen, we made some connections with the previous families to be able to visit each other and learn about how they coped in this situation. So that was a kind of a basic how a veteran group should be established in a later stage. We also developed a sustainable feedback model to measure parent experience. I think since the FICare survey, most of the units had no kind of reliable parent experience, or what you can call kind of that it's repeatable and sustainable, and you can identify areas for improvement. So again, with our multidisciplinary team, we tried to design one, and which also able to see some changes with family integrated care. So from the FICare survey, we just identified some relevant questions in view of FIC. And we basically, you probably remember that the FICare survey had a specific scoring, but we used the 10-point Likert scale that you can follow more changes in that. And we have left out all the questions where we actually scored very high on the previous FICare surveys, or which was not meaningful in our unit settings. And really just left questions which were kind of our scores were quite low, and where we hope that family integrated care can bring improvement. Additionally, we used the UNICEF Baby Friendly Initiative audit feeding tool, and we converted also to a short written questionnaire about breastfeeding and bottle feeding. We left some space for free text feedback, and you can see that kind of this word cloud was created from that. And with our psychology team, we have used some anxiety and depression score, and also this Morse test, which is kind of an assessment of parent-baby bonding. So we did this kind of feedback for all the admissions in 2015, and we're just about to send it out to the 2016 population. And we hope that how we involving and getting on the family integrated care pathway more and more, we can use these data as retrospective control to capture some of the improvement. So when we started this quality improvement project, we had a vision, which is very important, to create an experience co-design and competency-based training material for our families. So the methodology came a little bit kind of longer after, because first, again, we wanted to design like a paper-based material, and then we realized probably in 2015-16 that what you need is more an electronic material, which is easable, can be shared between different units. We were hoping to implement this wider to our network, but also can be accessible to other people. So that's when we decided that actually it probably needs to be a mobile app. We have made all the material available on paper as well, because you always will have families who don't like smartphones or not keen to use kind of high technology. And all the 3 parents who are coming on the parents panel basically have achieved family integrated care during their stay, but we haven't had the structure around. So they stayed between 4 to 6 months on the unit, and by one-to-one teaching with our nurses, they learn how to do the cares, how to do charting themselves, how to maybe do tube feeding, but there was no kind of structure, documentation, competency assessment. What Karen said, that the babies will have, or the mothers will have signature and competency proven, so in the next shift they don't have difficulties convincing the nurse that they're capable of doing those tasks. And of course we had to create also our training material for our own staff. We again learned from the Mount Sinai team that you probably need additional staff. And I think in the last 2 years, since we're trying to kind of implement fully this care model, it just again confirmed that we are right. We have, again, kind of a variable high nurse vacancy, which is kind of anything between 15% and 30%, depending how we are at the present, and also problems with retention and new staff. I think the NHS now getting so tight about funding, energy, and resources that you can't go that extra mile always with just your original establishment. So it was very important for us that we need funding to have 2 nurses on each, one in each side, one whole-time equivalent nurse who will be able to coordinate and be the link between families and the staff and the neonatal team. We also heard from the Mount Sinai team that once their randomized study finished and they lost their research nurse, Claire, who we'll meet in the afternoon in your workshop, that actually it was difficult to maintain the same level of FICare, even in a unit which had a culture already running for several years after the pilot and randomized study. And they also felt that definitely an extra resource is helpful to keep the things moving. We're hoping to get a psychology assistant additionally as well, who will help us to capture outcomes. So we would like to do some semi-structured interviews around the time of discharge to assess the effect of this care model. And because we went with the app model, we will have some iPads available for the parents on the unit, what we can lend them for their length of stay if they would like to use their app. And of course, they can do that on their own smartphone. So the care model and the proposed strategy is pretty much similar what we heard in the morning, that the parents would be informed about this different care model on admission, and they can start to use the app material as soon as they admitted, even when they are on intensive care, because the educational material contains a lot of information about how to cope in that situation and just increase their knowledge around medical things. And whenever the baby is medically stable, what we define off intensive care, they will have the opportunity to complete their competency-based program and be more and more involved in their baby's care. We are not separating between family integrated care and our normal routine care. We hope that this is gonna be a standard of care in our units, and a lot of older parents will start their competency-based training because we have like orientation on it, we have hand hygiene, and different aspects of the beginning which will be useful for every single parent. And those parents who are engaged and would like to make that further step and complete all the further skills, then they can take that on themselves. But it will be a universal thing for every family on the unit. We are very proud, and again, this was an advice from the Canadian team, that all our illustrations in our materials are our own ones. So we either did some photo shoots and filming on the unit, and we're going to show you a short film about ward rounds in our workshop. But also we just asked them to send us pictures after discharge, and they selected wonderful moments. And even if you have a professional film crew for a week on your unit, I don't think you're always able to capture those moments. So we're very grateful for our parents. We had a very extended kind of parental focus group, and I think over the last 2 years we had about 6 parent focus group events when these materials were finalized and co-designed and modified to make sure that they fit for purpose. as Bob said, we went along with the QI Hub with their support, and we have used some different QI methodology. This is just our action effect diagram showing what are we trying to achieve and what going to be the measures, which hopefully can help us to identify some improvement. This is one of the parents' feedback, on the focus group. And again, I think it's a good summary how the parents can feel. And helpless and being a spectator are two words which are very often come up in a traditional neonatal care model. And again, they feel that all the healthcare professionals knew their baby better than themselves. And I think we have taken that control away when a preterm baby is born. And it's time that we involve them and the parents can feel as a mother, as Carol said, from the very beginning of her journey. So when we went to Mount Sinai, we aim to have kind of actively observe that care model and possibly identify different aspects we don't have and we can implement in our service. And it was also important that actually this, the team who went to visit will be able to provide an extensive feedback to the entire team. And as I said, we realized that we have a lot of existing values already, and basically we are doing FICare in a small scale already, but it's not visible as a care package, as a care model, and that's why we designed all this structure and strategy. So in the workshop, we will share all this material with you, but basically, the mobile app has been launched this morning, so it's available in Apple Store from today, and also will be available in a couple of hours for the Google Play Store as well. We're very proud because it was a lot of work and a lot of information governance issue to sort out, so we had a delay of launching, but I'm very proud to say that today it's out. We have all the material in a parent binder, what we will share in the workshop, and we have prepared our competency assessment booklet and parent observation chart. And we try to adopt those to our local kind of policies and local circumstances, using all different other charts like the Toronto one or different Canadian units to find the best way. The mobile app has no connection to any patient data or any hospital system, and it's basically can be the parents' documentation of their journey. The parents can create one account for their baby with registration by their name and email address, and the mom and the father can share that one account. It's also able to handle multiples, so you only need one account to create. And just again, my colleague Jay Banerjee will talk extensively about that, but basically it has a few functions. You have a bit of passive function or non-interactive phase, which is the educational curriculum, and that contains 15 chapters about neonatal care. The 15 chapters will cover from kind of life in the neonatal unit, admission, down to discharge planning. On a work document, these are documents between 5 to 20 pages with illustrations and documentations. And we are able to show you, on the workshop how they look like. We have designed a developmental timeline, and again, that's something we're very proud of. Many mothers will use pregnancy apps now, and when they deliver a 25-weeker or a 26-weeker, they just lose track and they don't know what is developing, what is different, and how they are. So we have tailored one, we have designed one which is tailored for babies who are outside in the neonatal unit. It's running from 23 to 42 weeks, and you open up, you can read about general development, sensory, motor, behavior development, neonatal intensive care generally at that point in that week, and that how can you get engaged and involved in that baby's care. It contains a short glossary of terms. And the other interactive function is that the parents can just document their journey in a diary. So it contains a personal diary for memories where you can upload text, videos, and films, photos, and you can chart expressing, feeding, skin-to-skin, and growth chart. It does have some notes and messages function, and we will show that at the workshop. it again, it was co-designed with parents, and it's not really for health professionals, this app. I mean, maybe you want to read the chapters and see, how are we approaching different things like journey to suck feed or medications or so on. But this is a parent supporting app, and the initial feedback we had from our focus group was really great. This was funded by Imperial healthcare charities, so it's a free app and it's downloadable, internationally, nationally, and we hope that it will support the parents and it will be helpful outside Imperial as well. As Liz said, there is a lot of collaboration going along, and we hope that the national collaboration group will grow, and more units sharing their experiences and how they kind of tailored FICare into their settings. And we try to have, carry on with the collaboration with Mount Sinai Hospital, and we're looking into some basic project in low resource settings, where again, this probably even could affect mortality. I think the change, what we heard about the China model, I think in Western world you will not see such a striking outcome data because you will not have such a big contrast in the care after implementing FICare. But China showing developmental outcome differences just by this care model, I think is really striking. So it's probably fair enough to say that even in low resource settings, it may reduce mortality. We are very grateful for all our families who kind of participated with their time and with their energy in their focus group. And again, we have a Facebook page where we try to keep you updated about all the details.
Thank you very much, Aniko and Liz.